So in the first line setting, for most of our hormone receptor positive HER2-negative breast cancer patients, we give them an aromatase inhibitor plus a CDK4/6 inhibitor. And then the second line setting is a lot more nuance and ways to figure out how to give our patient a therapy based on mutations that have been acquired or that the cancer had from the very beginning. So for example, you could consider doing an aromatase inhibitor to fulvestrant and continuing the CDK4/6 inhibitor. If they have a PI3 kinase or AKT mutation, you could add in alpelisib, or you could do capivasertib. Or if a patient has no PI3 kinase or AKT mutations, you could do everolimus as a partner for fulvestrant. We have a lot of oral SERDs now and a PROTAC, vepdegestrant, which was reported out at this conference. Those are all in the mix right now. None of them are approved as combination therapies. And so these are monotherapies that have so far been tied to ESR1 mutations. ESR1 is a mutation, an activating mutation in the gene encoding estrogen receptor that develops as a resistance mechanism to estrogen deprivation with an aromatase inhibitor. And so the reason that that is important is because those cancers that have an ESR1 mutation, we know were at some point addicted to estrogen. And now going forward, those patients are more likely to continue to respond to endocrine therapy than those cancers that maybe were never estrogen dependent in the first place. So after we exhaust endocrine therapy in these patients, then we eventually get to chemotherapy, but some of the art of treatment of hormone receptor positive HER2-negative breast cancer is, when do we do that? When do we switch over to a chemotherapy-based strategy? It certainly wouldn't be wrong in our patient population after a progression on a CDK4/6 inhibitor plus an aromatase inhibitor in a patient who has an ESR1 mutation to do a therapy that is an oral SERD or a PROTAC that's approved for patients with ESR1 mutations. But a lot of us, especially in academics, are still doing a doublet rather than a monotherapy. So in the future, it's hoped that these combination therapies with oral SERDs and PROTACs in combination with something targeting the PI3 kinase pathway is probably going to be the way forward. So for the CDK4/6 inhibitors, ribociclib and palbociclib tend to have a lot of the same side effects, which is just that you do some 3 weeks on, 1 week off because of the neutropenia that develops. You can have GI side effects, but they're not as common as with abemaciclib. Abemaciclib doesn't have as much as the myelosuppression. It's dosed twice a day for continuously instead of 3 weeks on, 1 week off, but patients can get more GI toxicity, at least in the beginning. In this ASCO, the TRADE trial was reported out, which showed that a dose escalation strategy with abemaciclib can ameliorate some of the GI toxicities, which is very important. For those PI3 kinase pathway inhibitors, there is a class effect of development of diarrhea, hyperglycemia, stomatitis, and rash to varying degrees within that pathway. So for example, everolimus tends to have more stomatitis. It can also cause pneumonitis. The alpelisib and inavolisib can have more of the hyperglycemia, and capivasertib, because it's dosed 4 days on, 3 days off, is a little bit different because patients tend to develop diarrhea toward day 4 or 5, but then they have 3 days off, and so that can be a relief for a lot of patients. So especially in patients who are on fulvestrant plus PI3 kinase pathway inhibitor, right now I think a lot of us are using capivasertib as our drug of choice if the patient's tumor has PI3 kinase mutations or AKT mutations, because it does tend to be the best tolerated among alpelisib and inavolisib and capivasertib right now.